Let's dive into this with a quick look at our structural map. We'll start up in the neck with cervical tuberculosis, then move logically down into the abdomen for intestinal TB pathology and its management. After that, we'll shift gears to enteric fever and typhoid, and then wrap up with those critical, life-saving typhoid surgical interventions.
So, kicking things off with Section 1, tuberculosis cervical lymphadenitis.
Imagine a young patient walks into your clinic. They've recently arrived from an endemic zone, say the Indian subcontinent, and they present with cervical lymphadenopathy. Well, there is a golden rule you just have to follow here. Whether that swelling is in the jugulogastric, submandibular, supraclavicular, or posterior triangle chains, you have to treat this patient as having TB until proven otherwise. Let's walk through exactly how this disease progresses locally. It's really a step-by-step process. It starts out as a firm, painless, matted lymph nodal mass. Then, as internal caseation, which is basically this cheese-like tissue necrosis, progresses, the mass turns cystic. We call this a cold abscess. And it's called cold because it completely lacks the classical signs of acute inflammation. You won't feel any warmth, and there's no overlying erythema. Next, this cold abscess, which is sitting deep to the deep cervical fascia, bursts through a tiny defect into the superficial subcutaneous space. This creates a bilocular, color stud abscess that shows cross fluctuation. And finally, it bursts right through the skin surface. This forms a chronic tuberculous sinus that eventually breaks down into an ulcer. Because the bacillus actually destroys subcutaneous fat way faster than it destroys skin in that relatively anoxic environment, you're left with an ulcer that has a watery discharge and those classic, highly distinct undermined edges.
Now, while Mycobacterium tuberculosis is definitely our primary suspect for a cervical cold abscess, we absolutely must differentiate it from cervical actinomycosis, which is caused by Actinomyces israelii. This is a critical differential, guys. Actinomycosis has a very unique presentation. It has this woody, hard induration. It just ruthlessly crosses anatomical fascial planes like they aren't even there. Plus, its discharge contains these pathognomonic sulfur granules, which are basically tiny yellowish clumps of the bacteria. And the reason this distinction is so massive is the treatment. Unlike TB, actinomycosis actually responds to high-dose penicillin, not your standard multi-drug anti-tuberculous chemotherapy.
So how do we actually lock in this diagnosis? Well, our toolkit includes checking for an elevated ESR and CRP, and utilizing interferon gamma release assays, or IGRAs. These are modern, in vitro blood tests that are incredibly effective for picking up latent infections. On the microbiology side, we're doing Zeal-Nielsen staining of sputum or aspirates, looking for those acid-fast bacilli. Now, if the diagnosis is still blurry during those early adenitis stages, we might go for an excision biopsy. But right here is a vital clinical pearl. That X-sized lymph node must be sent to the lab fresh and unfixed for immediate processing. If you put it in a fixative, you seriously risk ruining the entire diagnostic yield.
Moving right along to Section 2, intestinal tuberculosis pathology.
So, traveling down to the abdomen, how does the bacillus even get down there? Well, transmission typically happens when a patient who already has active pulmonary cavitary disease swallows their own infected sputum. Or it could be from consuming unpasteurized milk contaminated with Mycobacterium bovis, or even through hemogeneous spread. Once it sets up shop in the bowel, it causes some very distinct local pathologies, usually accompanied by some pretty marked mesenteric lymphadenopathy. Basically, the disease takes on one of two distinct forms, and it all depends on this battle between the organism's virulence and the host's immunity. First, you have the ulcerative type. This happens when the bug is just too highly virulent and overwhelms weak host defenses. The bacilli colonize the lymphatics of the terminal ileum and create these transverse ulcers. As those ulcers try to heal, they lay down heavy circumferential scar tissue. This creates multiple strictures that literally cause a structural bowel obstruction. On the flip side, we have the hyperplastic type. This occurs when the host tissue resistance is actually quite strong. The chronic inflammation triggers this massive lymphoid hyperplasia, which severely thickens the terminal ileum wall. All that massive fibrosis actually ends up shortening the bowel mesentery. It physically pulls the cecum upward into a subhepatic position, widening the iliocacal angle way beyond its normal 90 degrees.
Clinically speaking, these patients are usually dealing with weight loss, evening pyrexia, night sweats, and occasionally complex fistulae and ano that feature those same characteristic undermined edges we talked about earlier. If they have the exudative form of peritoneal TB, their abdomen will have this classic doughy feel when you palpate it. That's caused by loculated ascites and matted loops of bowel just clumped together. In the plastic form, things get even more intense. A dense fibrotic sac forms an actual cocoon around the small bowel, leading to mechanical obstruction. And here's something crucial. Intestinal TB can absolutely coexist with renal disease. If you do a workup and find sterile pyorrhea, meaning there are white blood cells in the urine, but standard cultures come back negative, you urgently need to evaluate for genitourinary TB. That can present as a heavily fibrotic, severely contracted thimble bladder.
Now, what's really interesting about this slide is Stirling's sign. It's a fascinating radiological manifestation of this hyperplastic ileocecal inflammation. It's a functional sign you'll spot on barium contrast studies. See, the terminal ileum is so highly inflamed, rigid, and irritable that it simply refuses to hold the contrast. It just rapidly spasms and empties it straight into the cecum. So when you look at the film, you'll see this completely empty or clear terminal ileum segment sitting right next to a cecum that is heavily filled with barium. It's a fantastic, high-yield radiological pearl that brilliantly signals severe, localized ulceronecrotic inflammation.
Which brings us nicely to Section 3, Managing Intestinal Tuberculosis.
Okay, when we talk about elective management, the absolute mandatory first step is medical. We're talking an initial course of standard multi-drug anti-tuberculous chemotherapy spanning anywhere from 6 to 12 months, paired with strong nutritional support. Actually, let me emphasize that. Surgery is explicitly not the first line. Only after they complete their medical therapy do we re-image the small bowel to check for any fixed fibrotic scarring that might be causing a persistent subacute obstruction. If surgery is ultimately required for that fixed scarring, the focus is heavily on tissue-preserving, conservative operations, very much like how we handle Crohn's disease. Your options include a limited ileocholic resection if you're dealing with localized hyperplastic masses. Now, if you have a single, short, isolated stricture, you go with a strictureplasty. That widens the bowel without removing any tissue, which is great for preserving vital bowel length. Segmental resection is on the table for multiple closely grouped strictures. And finally, a right hemicolectomy is reserved strictly for highly extensive ileocholic disease where a limited approach just isn't feasible.
Emergency presentations, however, well, they dictate a vastly different approach. These patients often roll through the doors late, entirely in extremis. They have severe dehydration, profound malnutrition, and often active pulmonary disease. The laparotomy principle right here is simple. Perform the absolute minimum life-saving procedure necessary. We have got to avoid a primary anastomosis because the risk of a leak in a patient who is this malnourished and actively infected is just astronomically high. The safer, mandated approach is resection of the disease segment paired with a proximal ileostomy and a distal mucus fistula. Get them stabilized first.
All right, shifting gears to Section 4, enteric fever and typhoid.
Our next surgical pathogen relies heavily on inadequate sanitation infrastructure and poor personal hygiene, which leads to folks ingesting contaminated food or water. The culprit here is Salmonella typhi, which is a gram-negative bacterium. And this brilliantly illustrates how the disease unfolds step by step. Once ingested, these bacilli selectively colonize the Peyer's patches in the bowel. This kicks off marked local lymphoid hyperplasia. Eventually, the tissue undergoes focal necrosis, leading to deep typhoid ulceration. If you look at it histologically, you'll see intense histiocytic proliferation right alongside pathognomonic erythrophagocytosis, which is literally where the macrophages are engulfing red blood cells. If this goes untreated, these ulcers will erode straight through the bowel wall, resulting in simultaneous, multiple perforations and severe hemorrhage.
So, what are we looking for at the bedside? Clinically, a typhoid patient will present with a persistent, high, stepladder fever that lasts about 2 to 3 weeks, along with severe toxemia. During that second week, keep your eyes peeled for rose spots. These are transient, blanching, rose-colored macules on the anterior chest and abdomen. Another vital clinical clue here is Fagad's sign, also known as relative bradycardia. This is an interesting one. It's where the patient's pulse rate fails to elevate proportionally with their highly toxemic temperature. So for instance, you might see a blazing temperature of 104 degrees Fahrenheit, but it's paired with a heart rate of only 80 beats per minute. That mismatch is a really crucial sign for differentiating enteric fever from other tropical bacterial infections.
When it comes to diagnosis, blood and stool cultures are your standard. Now, you might hear about the Weddell's test, which is widely used, but honestly, it has pretty low specificity. Instead, you really want to be looking at these inexpensive, rapid diagnostic field kits: multi-test dipsticks, Tubex, and Typhodot. These are immensely valuable. Why? Because especially in developing regions, pre-hospital antibiotic self-medication is super common, and that often renders standard blood cultures falsely negative. These kits can detect IgG and IgM antibodies rapidly, and they don't even require specialized laboratory equipment. They are a real game changer.
Let's wrap things up with Section 5, Typhoid surgical interventions.
A typhoid perforation is, without exaggeration, a dire emergency. You'll know it by the sudden onset of severe, generalized abdominal pain right around the second or third week of their illness. If you snap an erect chest radiograph and see free gas under the diaphragm, pneumoperitoneum, in a deteriorating typhoid patient, it is a perforation until proven otherwise. After you aggressively resuscitate them in the ICU with fluids and broad-spectrum antibiotics, you're heading for an emergency laparotomy. Once you locate the initial perforation, the surgeon absolutely must systematically run the entire small and large bowel. You have to identify any coexisting perforations or patches of bowel that are imminently necrotic. From there, surgical options vary based on the level of peritoneal contamination. You might do a simple primary closure after debriding the necrotic edges. Or you might need a local wedge resection, a segmental resection, or even decompression procedures like an ileostomy. Whatever you do, it must be accompanied by thorough, aggressive peritoneal lavage using large volumes of fluid.
So, the crucial point when you're finishing up and managing the wound is this. The abdominal midline fascia, the linea alba, is securely sutured. However, the overlying skin and subcutaneous tissue layers must be left completely open for a delayed secondary closure. Why? Well, in these inevitably infected, heavily contaminated environments, wound infection isn't just a risk, it's a near certainty. If you attempt a primary skin closure here, you carry an unacceptably high risk of fascial dehiscence, and you definitely don't want that.
Let's step back for a second and see how all this builds our clinical understanding. Perforations occurring during the first week of illness carry a significantly better prognosis than those occurring during the second or third weeks. This makes perfect sense when you think about it. Patients in the first week are far less nutritionally depleted, and they still retain stronger immune defenses. Rapid surgical intervention, getting in there before profound nutritional and immunological depletion sets in, is the absolute key to reducing mortality in typhoid perforations.
Which brings us to a final critical thought. We've just examined this complex interplay of immune responses, localized tissue necrosis, and precise surgical timing in managing both TB and typhoid. But as antibiotic resistance in these exact tropical pathogens continues to rise globally, how might these rigid, established treatment algorithms need to adapt in the near future? I mean, will conservative surgery still be viable if our frontline medical therapies start failing? It's a profound challenge for the next generation of surgeons. Thank you so much for joining me on this explainer. Keep studying, keep asking those hard questions, and I'll see you next time.